Hi, this is Elliot Fishman, and welcome to our latest Facebook Live. It's today's Wednesday. It's about 1 o'clock. Welcome here. You see the sign in the back? How to draw this great sign. Join us in fabulous Las Vegas, Nevada. You and Elvis Presley. We start our meeting tomorrow. It's our annual or biannual, or it's our annual Las Vegas meeting now. We'll be at the Mirage Hotel. It's the same place where Love is by the Beatles, so you can see Love and listen to me lecture. Or you can just go to Love and then not listen to me lecture. But nevertheless, it should be a great meeting. Perry Pickard's there from Wisconsin. There's a bunch of Hopkins people. So it should be really good. And it's never too late. You can register on site. And if you use my name, I'll give you a $50 discount at the thing. Anyway, so today I'm talking about protocols, but I just, Ron Zember, who's my son-in-law, called me up and he said that Apple just announced their new laptop, the new 16-inch. So remember, Apple at one point made 17-inch laptops, but then they stopped them and only made the 13 or 15 MacBook Pros. There's always the Apple Air, which is like 10 or 11 inches, but the new 16-inch, and because Apple always works really well, remember they measure the screen. So I'm told that the screen is 16-inch, so it's bigger than the screen from the 15-inch. That makes sense, or it wouldn't be called 16. But the actual computer is smaller because they've managed to get rid of things that are on the side and everything else. But the biggest thing about it is it has 8 terabytes. So I bought my last computer 4 terabytes, which was a miracle because it was more than 2 terabytes. But right now I'm at 3.7 terabytes, so it's getting a little sketchy. The computer runs slow because you're not supposed to be running at 80% full, which I do, of course. So I'll get 8 terabytes, so I'll be back to less than 50% full. It's a miracle. We can do 1,000 more years of CTisus. And it's interesting, 8 terabytes used to cost about $500,000 to $1 million about a decade ago. And now you can get it for $2,000. So that's pretty cool. So let's see, Jay and Jamie are saying hello from Jayhawk CT, and Alberto from Oklahoma, and Nicholas from Madrid. So hello, everybody. So we're going to talk about protocols, and actually the first talk I give at the meeting tomorrow, so I'm flying out to Las Vegas later today, so and I'll be there in time for my own talk with a little bit of luck. But the first thing we speak about at any meeting is protocols, because at the end of the day, we always make the point that with the right protocols, everything else works very easy. If you look at the ability to read studies correctly, if you have bad protocols, you really can't read studies correctly, right? You're going to miss a lot of things. You're not going to see the pancreatic tumors or the liver tumors or the kidney tumors. You're going to misclassify things. You're going to undercall gastric pathology or overcall because the stomach's not distended. You're going to make mistakes in the small bowel. You're not going to have a good cardiac CT. You're going to miss lung nodules. You're going to confuse a mass with a vascular structure and a vascular structure with a mass. There are an infinite number of errors you could make. But if you do the protocols correctly, you could basically, I won't say eliminate errors, but you can really minimize errors if you're very careful. So we put a lot of effort into protocols. Now we use a lot of dual phase imaging, okay? Not more than you should, but we use the right amount, I believe. It's important to recognize my biggest thing about radiation dose always is when I'm saying that doing the study right the first time is the way to decrease dose. If you do the study wrong because you did less and then you got to do it again, you're actually giving more dose. So in that sense, it's just you need to be careful and do the right study. You got to do the right phases. So we talk about protocols. We talk about oral contrast. I was just at a couple meetings. I was at the Baptist meeting, ER meeting in Boca Raton. I was in New Jersey Radiological Society. I was at UCSD in San Diego. And one of the big comments people have been making, and they're very frustrated, is that the ER docs are really pushing for no oral, no IV, just scan the patient. And their feeling is that a scan is a scan, you get the same accuracy. And we all know that's impossible. And if you don't do the study correctly, you're going to miss a whole lot of stuff. Biggest complaint, and the thing I argue about the most, is oral contrast. They don't want you to give any oral contrast. Now, we can argue when you should give positive or when you should get neutral contrast, which means water, but giving nothing is sheer madness. That means the stomach is not distended. A patient with abdominal pain could have a gastric ulcer, gastritis, lymphoma, many gastric pathologies. You're not going to see them in a non-distended stomach. And if the stomach's not distended, you could overcall it as a gastric pathology, or you can undercall it. You can make all sorts of mistakes. And all you have to do is give 500 cc's of water or positive Omni 10 minutes before the study, and you would get rid of all of those errors in the stomach and duodenum. I don't see the issue. The patients are always thirsty. They want to drink it. It's not going to affect renal function. It's not going to affect anything you're going to do after. For some reason, the ER docs, not the ER docs at Hopkins, of course, but for some reason, the ER docs everywhere else somehow think that giving oral contrast is delaying the study. They spend 5 hours screwing around with the patient, and they want to know why radiology spends 30 seconds. Well, I'm telling you, I'm the one reading the study. Read my lips. I'm the one reading the study. I'm going to tell you how the protocol needs to be done. And my responsibility is the patient to do the thing right by the patient. So we're giving oral contrast. Positive versus neutral. Now this premixed positive, you can use oral Omnipaque. If you had a perforation, you would see it. This positive is really good for perfs, fistulae. But if it perforated and went into the peritoneal cavity, let's say the patient had a leak, it's inert, so there's no problem. If the patient aspirated, there's no problem. We're not giving gastrografin. You don't give gastrografin. It tastes terrible, and there's all sorts of complications. We're giving oral Omnipaque, FDA approved, okay? Really no issue. And you can see John is saying hello from Peds CT. John's lost today. He went from Peds over to, from body over to Peds. But John will tell you that we tell all of our techs that when the patient gets on the table, give them an extra cup of contrast. Nobody ever got yelled at for giving too much oral contrast. You get yelled at, or we would quietly tell you, give oral contrast. What are you thinking? Okay, that's number one. What's the issue with IV contrast? Patient has an IV already. IV contrast is very safe, except in a small number of patients who have contrast, who have nephropathy, or the few people who are allergic. We know that a lot of what we know about contrast is all wrong. These things about patients getting bumps in creatinine, some people bump their creatinine on a daily basis. It changes. It's not static. And there have been many articles written by Davenport and others about that. So we know that the number of people who get contrast nephropathy is rare. And when it does happen, it doesn't happen after a CT scan. It happens after an angio with this interventional, and there's not 100 or 120 cc's of contrast, but something like 300 or 400 or 500 cc's of contrast. That's when you see problems. But at the levels we do things, we're not seeing problems. Why are you making a problem? We know that you're going to miss a lot of liver lesions. You're going to miss a lot of pancreatic lesions. You're going to miss a lot of kidney lesions. You're going to miss a lot of splenic lesions. You're going to miss a lot of vascular lesions. You're going to overcall. You're going to undercall. You're going to do everything wrong. You give IV contrast, you know the answer. You give oral contrast, you know the answer. I don't have an answer why people make such a big deal of it. Let's see, Carl Tucson, greetings from JHCC surgery waiting room. Hope everything goes well, Carl, and I guess we can look at ourselves as a distraction. But no, I think it's really, it's very important. And I think if you don't give oral, you don't give IV, I see many misses. You overcall and you undercall. You don't detect subtle pathology. You miss renal masses. No IV contrast, you miss renal masses. You miss pyelonephritis. You miss vascular malformations. You're good at calling stones, but that's not what the person has, okay? Stones is great. You also misclassify. You see the mass in the kidney, you say it's a tumor. It's really a high-density renal cyst. Those are the things. Looking at the pancreas, you're going to miss most pancreatic cancers when they're small without IV contrast. You look at the liver, maybe you'll see a mass, but you don't know it's hemangioma, hamartoma, hepatoma, metastasis. Give IV contrast. You can look at the enhancement pattern and many other features, which we've spoken about before, and make the right diagnosis. So I'm saying to you that if you don't give IV and oral contrast, you're doing a bad study. Now, I spoke to some people recently who do teleradiology, and they say the biggest frustration is they're reading scans from many hospitals where they have no control how the studies are done, and they know the studies are not done as well as they should. Now, I think radiology, organized radiology, is a bunch of wuzzes, okay? Now, I don't know who organized radiology is, but whoever they are, they're a bunch of wuzzes, because they should just say, no, we need to do studies right. Don't fumble around and trying to be Mr. Nice Guy or whatever. No, we got to be right by our patients. And giving oral and IV is critical. Doing the right study the right way, delivering contrast the right time, acquiring the right data, interpreting correctly, doing post-processing, doing multiplanar, doing 3D. Only after you do all of those steps perfectly well could you say that you made the best diagnosis possible on the patient, whether you see something or not. And I think we need to basically take responsibility and say, no, we're not listening. The Who wrote a song about oral and IV contrast. Remember the Who, like, Peter Townsend, Roger Daltrey. There was 4 Who's, and now there's only 2 Who's. 2 Who's are gone, unfortunately. Keith Moon, remember the world famous drummer, and then the bass player, whose name I'm blocking out. He never moved, but he played really good bass. But the point is that Who said, one, we won't be fooled again. That was one of their songs. They also said, I hope I die before I get old. Now they're old. They don't want to die, I promise you. So they don't sing that anymore. But the Who said, we ain't going to take it. Never did and never will. Well, we ain't going to take it. We ain't going to listen to a bunch of people who don't know anything, how to do studies, telling us how to do the studies and how to take care of our patients. Yeah, they are ER docs. I love ER docs. They're very good. Emergencies come in, you see TV shows. I mean, it's unbelievable what those ER docs do. The problem is a lot of the ER docs think they're on CBS or NBC. You ever notice that on ER, there's no radiologist, there's no pathologist, there's no anesthesiologist. The ER docs do everything. They do brain surgery. There's no surgeons. They scan the patient, they read the scans, they operate on the patient, they discharge the patient. It's amazing. Well, the ER docs aren't the ER docs on ER. The ER, let me just tell you, that's fantasy, okay? That ain't real life, okay? Real life is the ER docs have an important job. They're the ones triaging the patients. Critical. Decide what's wrong, what you think is wrong, but then you order an imaging exam. We come in, we look at what you say, we speak to the patient, we give the best study to make the best diagnosis as quickly as possible to move the patient's care along. Articles have shown clearly that even when someone says appendicitis, best people saying appendicitis, they're only right 25% of the time, but in the rest of that 75%, more than half of them will find the answer why they have the symptoms. Physical exam and clinical history and patient symptoms are only good so far. There's a million things that give you right lower quadrant pain. CT, we know those million things and we can see them. And hey, Whitney's here. So Whitney Fishman-Zember is listening all the way from New York. And I wonder if Max and Sam are listening. Max is one of my biggest fans. He'll be doing one of these talks sooner or later also, next time he's in town. But I think, I think we, it's and I'm really not joking about that because, and I think many radiologists, the meetings I've been to, everyone's been very frustrated. They ask, what could you do? Because I think radiology has basically taken a step backwards and say, it is what it is. Well, it ain't what it is. It's what it needs to be. And just say no. What are they going to do? They're not going to order scans. They're going to report you to the head of the hospital. If you put in your protocols, this is how we do the study, that's what you need to do. You can't say, well, the ER doc wants us not to do it. That's not a good thing. Christy Cole, the topic is a constant struggle in a small rural hospital. No, the problem is, particularly at night, I feel really bad for the techs. The techs know better, but you have some ER doc who's telling you how to do the study because the radiologist is not there, or the radiologist who's reading is 1,000 miles away. 1,000 miles away, that's like that Jackson Browne song, Running on Empty. No, I think it's Stay. That's the one when he says, on the album, it was done in Columbia, Maryland, only 20 minutes from here. I was at that concert, actually, where, he says that, you'll be in your town. When the sun comes up tomorrow, you'll be in your town, and I'll be 1,000 miles away. It's interesting. That's the exact words that Jackson Browne uses. Hey, look, Lily, do I sound as good as Jackson Browne when I sing that?
Yes.
Okay, all right.
Yes.
Lily's a very big liar. Okay. Okay. I don't understand why it sounds so much worse when I say it than when Jackson Browne sings it. But nevertheless, Jackson Browne and I are on the same page. You have to do the study correctly. There's no ifs, ands, or buts. I think what we ought to do, maybe we can organize it through CTisus. We ought to get famous rock stars endorsing our policy for ER, oral and IV contrast material. We can get Adele to maybe sing about it. Adele, when she sings, everyone, it's amazing. I saw her in concert last time. I was 10 feet away, and she's releasing an album. I think it's next month. She'll be touring probably next winter. Greatest concert I've ever seen. Even better than Taylor Swift. Maybe we can get Taylor Swift to endorse it. If we get Swiftie to endorse it, then people would demand it. We can get the Eagles. We could get the Who. Who else can we get? Anybody else we can get? Katie Musgraves. She'd be fantastic. That'd be really good because she sings with a lot of passion. Or Ellie Goulding just released a new album. Really, really good. I love Ellie Goulding. We need someone with passion. We can't have some woozy group, like playing, background music or something, or elevator music. We need a group. Maybe I'll ask Whitney. Hey, Whitney, you know any good groups that we can get? Let me see here. Let me see what they say here. See, everyone agrees with me. From Ayer, Massachusetts, Rebecca, Deborah Brown, Alberto in Boston, Giacario, I killed a name from Italy. I just think we need to make certain because we need to do the right thing. If you want to know more about that, we can talk about it some other time because I guess I'm running out of time. But also, just come to Las Vegas. I mean, what are you doing the rest of the week? There's nothing. Thursday, Friday, it's the end of the week. And it's cold on the East Coast. It's really cold. It was like 23 degrees this morning. And if you live in the Midwest, wherever that is, it's kind of the west of us, it's like freezing. I saw it's like 5 degrees or something. Las Vegas is like 75, maybe low 70s, low 50s. Very, very pleasant in Las Vegas. And the Mirage is really good. It's right next door to Caesars. You go to Mirage. There's some lions. You probably don't get eaten by the lions, but there's some lions there. You go see the Beatles. That's always a good thing to do. You walk over to Caesar's Palace. You could roam the streets. And we have really good lectures, I'm telling you. No one's better than Perry Pickard and myself. I mean, what can you ask for? Steve Rowe. Who else is there? Steve Rowe. Jan Fritz. Jan Fritz is there. And Atif Zahir. So it's really good lectures. 3 days, like 18 CME credits. Anyway, I think I'll stop there. And here's a good shout out from Dubai. I once went to Dubai. I was there for 1 day. Dubai was really nice. It's a lot of really, really tall buildings. It's really cool looking. I have to get back to Dubai. And the thing about Dubai is you fly those really good airlines. If you fly like Emirates or one of those airlines, oh my God, they got to take you off the plane because you don't want to leave because the plane is so nice. Usually when I'm on a plane, it's like United or Southwest. You're running off the plane as fast as you can because you don't want to catch some disease from the seats or something. But when you're in, like Emirates or whatever there is, not Dubai Airlines. I think Dubai, whatever the airlines is, they are really good airlines. And they're always rated like #1, and it's beautiful. As long as you don't go to Dubai, probably in the summer when it's 120 degrees. And I know that Lydiana and her husband were in Dubai for about a decade. They say only the greatest things. So with that, and then here's from Ghazi from Saudi Arabia. So we've covered the globe, right? Saudi Arabia, Dubai, Boston, Baltimore, Massachusetts. That's about all there is. The rest is a bunch of water in between. And from Mexico, Madrid, Oklahoma. That's pretty good. And just, people always ask us, how many countries do people come from to CTisus? So we roughly have about 220 countries, which is amazing because I can name on my own like about 13 countries. It just aren't, but there's 220 countries, 225. Sometimes we have like people from like foreign, but that's really the real number. I do sometimes think we have people from other galaxies as well. Sometimes from other planets, other galaxies, other universes, but it's a little bit hard to keep track of those people. They don't sign in exactly correct. Anyway, hopefully this helps. And I think it's really, all joking aside, it's something radiology needs to be very serious about. The right thing, the right study, done the right way for our patients is really what radiology is about. And with that, I hope to see you next time and have a great weekend. Hopefully I'll see you tomorrow in Las Vegas. Be good. Bye.